talk. Professor Abu Tahon, please. And congratulations for initiating your postgraduate course in Jordan University.
Yeah, thank you. We really have started this year the postgrad program, which is a clinical master in endodontics. And hope, inshallah, we can collaborate with you and with all these great names I see in front of me. Dr. Merich, my dear friend, Tugba Turk, and all the other colleagues. But first of all,
Professor Abu Tahon, before you go further,
what happened, Mohammed? Something happened.
I think he lost connection.
Yeah, no, yeah. I hear you now. Now I'm back now.
We do hear you, but Dr. Nekofar is lost right now. Yeah, I think he lost connection. Probably he will join in a few minutes.
Yeah.
Seconds, probably.
Hi, Ibrahim. How are you?
Yeah, I'm waiting. I'm waiting to welcome you in Greek.
We can speak in Greek language, I think.
Of course. But I'm waiting Nikofar to come back so I can welcome you in all languages. Yeah, nice meeting and seeing you. And
yeah, I missed that part, Professor Abu Tahon. I'm disconnected. I missed that part because
this is why
Abu Tahon graduated from Greece, and he always said that Greece is in his second home.
Yes.
Not only this, I left Greece, but I left my heart in Greece. Anyhow, really, I want to welcome Dr. Giorgos Tzanetakis from University of Athens. I want to say that for 13 years, Athens and University of Athens were my home. So, you know, the nostalgia for Athens and for the University of Athens. And in Greek language, I would like to να χαιρετίζω τον Γιώργο τον Τζανιτάκη. Νιώθω πολύ χαρά to see you, to unfortunately I go to English always to...
Και εγώ νιώθω πολύ χαρά να σε έχω μαζί μου εδώ.
This is very good. George, see, we have a lot of surprise for you. So you should join us and we carry working with each other.
This is Greek language.
Great. And now, so we have Professor Sanjay Miglani, the ex-president of Asian Pacific Endodontic Confederation and the Dean of the Educational Committee. Sanjay, we are going to start so you can have your introductory talk. Please unmute yourself.
Yeah, I am unmuted. I hope you can hear me.
Yes.
Oh, we have a conference tomorrow morning, so I am driving down to Agra right now. So that's why I am attending from this. Anyway, good luck, Dr. Nikofar. It is a pleasure working with you in Education Committee, and I hope you will keep on doing well. My best wishes to the speakers and the moderator. Thank you so much.
Thank you very much. And one of the persons who always support us is Professor Zimet from Australia. So thank you very much, Professor Zimet. When we see your face, and Professor Zimet is also one of the ex-president of APEC. So before you join us, Professor Zimet, we mentioned that we are going actually to make this club and this journal club as some of the official teaching session of the postgraduate for some universities that we involve in this. So from June, we are going after June, which is the last session that we do that on the shadow of the Asian Pacific Endodontic Confederation. We are going to have an agreement between some universities from around the world to have this club as a mandatory part for postgraduate courses of this university. So we will open an agreement, and whoever likes from the university to join and sign during these 3 months, that we'll still carry on doing this job because we already selected the articles and announced that. Then we are going to change it in another way and maybe make it a bit quicker each session. For example, half an hour for each session, but twice per month. Or we will discuss with the moderator of the postgraduate of these universities to find out the best way to do that. And today also, Professor Zimet, we have a change that the author generously offered us to have a presentation out of his article first, before Dr. Utku from Bahçeşehir University from Turkey is going to start the appraiser. Professor Zimet, please have some introducing word, and then we will start after that.
What you said, Professor Nekofa, is extraordinary, and it's this system is just progressing from height to height, and is a testament to your wonderful enthusiasm, and also to the enthusiasm of APEC and how we are developing APEC, and it's really becoming a force for education worldwide. And it's really pleasing to see this, and to see our Greek colleagues joining with us in APEC. So APEC is no longer Asia Pacific, it's Asia World. So we've been very fortunate. So we're looking forward to hearing you, and I hope our Greek colleagues enjoy this, the way that Professor Nekofa has set this up. I think you'll be pleasantly surprised.
Thank you very much indeed. Okay, George, we are ready for your presentation.
It's okay.
Now we can see that.
First of all, thank you once again. Thank you, Mohammed. Thank you, Utku, and thank you all the colleagues who participate in this event. It's I feel very honored of participating in such an event. It's the first time that I participate in such an endodontic study journal. So please forgive me if I seem a little bit nervous. And I have prepared some slides of PowerPoint presentation related to the work that it published in Journal of Endodontics about the factors that related to pulp survival after complicated crown fractures following vital pulp therapy. This is a systematic review, and meta-analysis, quantitative synthesis of results was followed. First of all, I would like to talk about the rationale of the study. The first reason for conducting this study was that no systematic reviews were existed on this topic, which would offer a comprehensive evaluation of the finding of the already existing studies about the kind of treatment, the technique options, and pulpotomy materials. And a very important issue is that we considered that the design of new well-conducted randomized controlled trials in the future, we considered that it was difficult, so we had to deal with the result of the existing studies. So we begin with the search strategy, the database that were used to find all the relevant articles were the Medline through PubMed, the Embase, the PubMed Central, and the Cochrane database for systematic review. We search for some reports, unpublished research through clinical trials or often gray literature. And we always, as you already know, that hand searching is required in order to have an adequate reference list of the retrieved articles, in order to not have any gaps for all possibly included publications. As we already know, the PICO question is very important when you have to conduct a systematic review. The PICO questions about the first P, about the participants. We searched for all patients undergoing vital pulp treatment, direct pulp capping or partial pulpotomy or full pulpotomy, both mature and immature tooth after crown fractures. And these crown fractures were complicated crown fractures. As you can see, no age on gender restriction was applied. The second letter is the intervention. The intervention, all kinds of all types of vital pulp therapy in teeth with complicated crown fractures. And we searched with comparators, about comparators, which were other type of vital pulp therapy or other materials with the same type of vital pulp therapy. And other injuries or such like periodontal or fluxation injuries. And the outcome was the treatment success. I think that pulp survival is more appropriate term because this is based on clinical and radiographic criteria, and in some cases we don't have a reaction or thermal or electric pulp testing. So all the criteria are based on clinical and radiographic examination, and if we have a positive reaction to thermal or electric pulp testing, I think it's the best option in order to define the pulp survival. And in immature tooth, we know that the progression and the completion of root development is a radiographic sign that all about our treatment or is good, and the treatment and the outcome is successful. So in this,
may I ask you, George, to go back to your previous slide, because I want to ask Utku if he has a question, or other participants, if they have a question in this part, they can ask you for that.
Yes.
Yes. Actually, Dr.
Utku?
I had questions, but I think maybe after this summarize, we can continue with my presentation. With this presentation,
so you
there will
prefer
be detailed
actually,
questions. Yeah, it's
to
better,
have your
I
question
think.
at the end of that?
Yeah, yes, because I also give some knowledge, some summary about the research, so it's going to be
in
easy
that case,
for
Dr.
the listeners.
Vatanpur, who raised his hand, also I'm going to ask you, Dr. Vatanpur, to write down your question for yourself, and then when George, the generous author who accept to be with us and give us this presentation, will finish his presentation and we come back to the question one by one. Thank you very much, because Utku prepare actually a presentation which is about the questions. Thank you. Okay, please go ahead.
Thank you. This is the flow diagram of article selection process. As we can see, 24 articles included in the qualitative synthesis of the results, and only 7 articles of them contributed to quantitative synthesis, to meta-analysis. The eligibility criteria were randomized control trials, or the prospective clinical trials, cohort studies, and case control studies. We had also cohort studies without a control or comparator group, but all the studies were not included in the qualitative synthesis, but were included for, as you can see, for comprehensive reasons. and we had no restriction regarding date of publications. We excluded all the case report and case series, and some studies with previously treated teeth, as well as studies with ineligible results. I can mention some of these studies if you want. Following. Some items about sample size for randomized control trials ranges from 23 to 205 traumatized teeth, and the respective numbers for observational studies were 9 to 30 to 375 teeth. As we can see, 6 studies involved only immature teeth, and the remaining 17 involved both mature and immature teeth. And there was one study where specific details regarding root formation could not be specified, even after a try of an effort of personal communication. So we can see the 7 studies that included in the meta-analysis. These studies contained intervention groups based on materials, the use of the material of pulp capping material. This is the 7 studies, and irrespective of capping material, based on the choice of treatment technique, or for example, pulp capping, direct pulp capping of pulpotomy, these 5 studies were included. I would like to say some words about the risk of bias assessment. Is very important during conducting a systematic review and subsequently meta-analysis. These are the 4 randomized control trials which evaluated about the risk of biams using the tool that was used was, as you can see, the ROB2 tool. It's the most appropriate tool based on the Cochrane library. It's the most accepted tool for assessing the risk of bias. And 4 randomized control trials were assessed. And we can see that the main disadvantage is that 2 studies, the studies by Rao et al. And Wu et al. Had some problems with the randomization process. Overall, the risk of bias was high because there are problems for the intended intervention of missing out data or the development of the second. This is the risk of bias assessment for non-randomized studies. All the other studies were non-randomized. This is the Robin-Sai tool. This is the tool that assess the non-randomized studies, all the other observation studies, and it's the most accepted tool based on the Cochrane library in order to do this process. This figure is about the random effects and meta-analysis of the 4 randomized control trials. I think it is the most important part of the meta-analysis, and we can see the first is that the evidence from 2 studies comparing bioceramic material. I think the bioceramic material is the iRoot BP+ versus calcium hydroxide in immature teeth did not reveal significant intervention effects. There is no significant difference between the materials. The second result is that no significant finding was observed when MTA was compared to calcium hydroxides, both in immature and mature teeth. And the third, I think the third result that has a significant meaning is that comparing pulpotomy with calcium hydroxide to pulpotomy with zinc oxide eugenol cement, there was 22% higher probability for a successful outcome for pulpotomy with calcium hydroxide. This is for a single study estimates result, and I think it's a result that has some significance because we do not no longer use this material calcium zinc oxide eugenol cement to make to perform a pulpotomy procedure. Some other findings. When different vital pulp management procedures were considered in a pool in both immature and mature teeth, there was no significant difference between pulpotomy and pulp capping when using either calcium hydroxide or MTA. This is, yes, and another interesting finding, when calcium hydroxide was used as pulpotomy or pulp capping material, there were 18% higher probability for successful treatment leading to pulp survival when no luxation injury had previously occurred. This is the result is valid only for calcium hydroxide and not for MTA. I don't know. I can explain this result, but I think when the luxation injury and concomitant luxation injury has previously occurred, I think this is a major problem for pulp survival, irrespective of the pulpotomy material or the technique. I think. This is my personal opinion. Okay, I think. The conclusions of our study is that pulp survival is possible when appropriate capping material is placed to cover the exposed pulp. We found no significant difference between calcium hydroxide or the most contemporary MTA and some bioceramic materials. If we have a periodontal injury, a luxation injury, it seems that there is a significant predictor of pulp survival, but the quality of evidence, as I said, was very low to moderate. So we should design more carefully clinical trials, which I believe is a very difficult procedure because it is about trauma, and all the clinical trials about trauma, it's very difficult to be conducted. Thank you for your time.
Thank you very much. Doctor, may I share my screen right now?
Yes, may I stop to share?
I think you don't have to. I think I can arrange it by myself.
Okay.
So, do you clearly see my screen right now?
Yes.
Dr. Nekopar, may I start? Doctor, do you hear me? Professor Nekofar, do you hear me right now?
He has
I
a
think
problem.
we have maybe only he has a problem about connection, or others. I think you hear me, Professor George. If you hear me, I think everybody.
Yes, I can hear you. I can hear you. Yes.
So maybe we can start. Dr. Nekofar, I think you say something, but we don't hear you.
Yeah, he is asking you to start, Dr.
Yes, I'm back.
Perfect.
Sorry.
Perfect.
I just had disconnected from the system. Sorry about that.
No problem. So, well,
Okay.
thank you very much for your.
Professor Abu Tahun is here. I'm happy that you take care of it.
Yeah, but no one can fill your chair. No one can fill your chair.
Oh, sorry about that. Okay, thank you very much, George, for your very comprehensive summarizing of the article. I'm sure there are a lot of questions.
Yes.
So Dr. Utku is going to show his presentation and we will take care of that. Utku, please.
Okay. Thank you very much. So, well, it was very good summarizing your research. Thank you for that. And so it was very, at the beginning, it was looking very hard to understand for meta-analysis for me. But when I read this article, it was really easy to understand the main subject and the other things. For me, thank you very much for this understandable language, and as a young researcher, it is very giving a light for our next generation. Thank you very much. I am coming from Bahçeşehir University, which is just on the Bosphorus, and I started my assistant professor career a few months ago. I hope I will be here. So this article mainly focused on complicated crown fractures prognosis, and also the effect of the material and the teeth and the pop capping materials effect on this prognosis. So first of all, I wanted to give some small tips about dental trauma. Traumatic dental injuries occur frequently in children and young adults, comprising 5% of all injuries. 25% of all school children experience dental trauma, and 33% of adults have experienced trauma to permanent dentition, with the major of injuries occurs before age 19. So dental trauma classification, I know these are very easy, but just for small tips, we know that enamel infraction, enamel fracture, and enamel dentin fracture. But in our main topics for today, it is complicated crown fractures, because pulp is involved with that kind of fractures. And also uncomplicated crown root fracture and complicated crown root fracture. This is also going to be our one of main focus in here, and we will have some questions about that. So based on existing literature, pulp survivor in complicated crown fractures range between 32% to 94%. It is looking very big difference in the literature. The preservation of pulp vitality is of utmost priority for us for pulp survival. So in immature teeth, it is very important to put vital therapy for the root development and the thickness of the root. But also mature teeth, we are trying to put vital therapy for the prognosis and for the other advantages. So my first question is about that. Why is it important perform vital treatment on teeth that have complicated root development. Because I'm also very focused on regenerative endodontics. At the beginning, we were using regenerative endodontics only for immature teeth, but then we started to put this treatment for the mature tooth also. But sometimes when I'm facing with the questions about that, because we have root canal treatments, and we know that root canal treatment has a very high success rate. And why do we need to do vital therapy in trauma cases? What's the advantages for us?
Yes, I think that we all know there are several reasons to do vital pulp treatment, vital pulp therapy on teeth that had complete root development. And I think if we cannot restore the tooth, we probably will perform root canal treatment. But all these patients are young patients, and it is very important. Even we have root canal treatment as a gold standard treatment in such cases with complete root development. It's very important to maintain pulp healthiness and pulp vitality, irrespective the completion of root development. The fact that all these patients are very young, the age between 10 or 20 years old, it is very important for me. And according to literature, I think to maintain and to pulp healthiness and pulp vitality.
Do you think is it related to the maturation of the apex or not? So I mean, if the apical part or apex is mature enough, still do you recommend the use of vital treatment versus root canal treatment?
Yes, because for me it is very important. I think, and according to literature, it is very important. All these teeth are young permanent teeth, irrespective of complete root development. So we have to try to perform vital pulp treatment if we have the chance to maintain pulp vitality. It is important.
And you are not worried about the calcification or obliteration of the canal as a result of this vital pulp treatment?
No.
And during your systematic review, how you find any result of calcific metamorphosis that ends up to full obliteration of the canal?
Yes, this issue is of some concern, but I, in my opinion, I don't think this is an important issue, because when do we see a pulp canal calcification? In most of the cases that we have left an inflammation inside the tissue. This is if we have some kind of inflammation without clinical symptoms, we have a continued calcification. If we have control the infection and the inflammation, I have a lot of cases with no pulp canal calcification.
Wow, this is interesting, because usually the reason of the calcification is described by the use of the calcium hydroxide or calcium silicate materials that may conduct hard tissue formation and ends up to obliteration of the canal. But now you're talking about another theory, which is very interesting. You're talking about control of infection may end up to healing rather than calcification. This is nice.
There are some materials, if you are aware about literature of biodentin, there are some materials that probably may calcify the canals or the pulp chamber, but MTA has not this disadvantage. If you control the area of inflammation tissue, there is no chance to continue to have a continued calcification inside the pulp chamber.
Great, great.
In
Thank
my
you very
opinion,
much.
I think this is very important. This happens. This happens.
From the audience and participants and professors, if there's any special comment about these particular things, calcification of the canal, please tell us. If not, we move to the further. Okay, George, thank you very much. This explanation, I think, is very novel approach. So maybe future studies can work for the comparison of different material to look at the calcification itself as a very important variable. And also this description to control inflammation may not end up to calcification. That means calcification is a type of disease of the pulp rather than the healthy situation. Great.
Thank you.
There is a question from the audience, Dr. Mutavassili, Dr. Fariba. She said that I don't understand what is the difference between MTA and other materials like biodentin and others that they can not create calcification, although others they may. So do you have any description for that or any other evidence for that?
There is, we all know that there is evidence that we have, if all is going right, then we have a dentinal bridge, and a dentinal bridge of a high quality dentinal bridge, but no complete calcification. We have a complete dentinal bridge, a high quality of dentinal bridge, but not a continued calcification inside the pulp changer if we perform partial pulpotomy.
Ah, yes.
This is
completely
two different things. Completely canal calcification and pulp chamber calcification and dentinal bridge below the material.
Very nice. Thank you very much. Merit, please.
And I would like to add that in case of calcification, I think this should not be a reason for avoidance from vital pulp treatment. We have microscopes and manage it during follow-up.
Yes.
Okay, Dr. Noor.
Thank you for hosting me, Dr. Nikofar. My question is about the calcified canal. Can we face calcified canal in children like between 10 to 20 age? And how many percentage can we know it? Because we know calcified canal in elderly people more than this age from 10 to 20. So how the percentage can we know that this canal is calcified in the children?
If I understand your question properly, you're asking George about the effect of age of the patient on the calcification. Am I right, Noor?
You are right.
Okay,
you are
George,
right.
please.
Yes. When we have young patients, the extent of calcification, if an amount of inflammation remain in the pulp tissue, is I can say is more evident. But the calcification in other ages, in older ages, is already there. So, and the development of a new calcification is related to the healing potential of the tissue. And in older ages, there is no healing potential. And the healing potential is less than young ages.
Thank you. Thank you very much. Utku, please make it a bit quicker.
Thank you. We know that traditionally calcium hydroxide has been used universally as the pulp capping material of choice, with relatively high successful outcome rates, reaching 96 reported in the historic study of Schubeck in 1978. So before this meta-analysis, I was thinking that we used calcium hydroxide in the history, and now we need to take it from another place, because I was always thinking that MTA and the other bioceramics are the top rate. They are the only choice for that kind of vital therapy. But with this meta-analysis, I saw that calcium hydroxide also still working for this vital therapy. So MTA was introduced, gradually replacing for calcium hydroxide as a pulp capping material. It has a capacity has been demonstrated by achieving even better outcomes rate, treating both caries exposed pulp cases and cases of traumatized cases. Bioceramic materials, their recent advancements in material science include the introduction of bioceramic materials in this respect. So when we continue with pulp capping, we see that many studies have examined the impact of complicated crown fracture injuries on pulp studies by using different techniques and pulp capping materials. Among these, only 4 are randomized controlled trials that you already included for this study. So the remaining are prospective and retrospective cohort studies for this perspective. So at this point, I want to ask you that as a young researcher, sometimes they are complicated for us to understand. So what's the difference between cohort study and RCT? Can you briefly explain for us?
Before George go to this part, I want to ask you also to add something to your answer and tell us in your systematic review and meta-analysis, you put together all this study, the cohort, RCTs, retrospective, prospective. Is it also correct to put them together for calculation or not? Please go ahead.
Yes. Let me ask you the first question by Utku. Yeah.
Yes.
The main. Yes, there are cohort studies and randomized control trials. The main differences is the randomization process, and cohort studies may be retrospective or prospective. If we have a retrospective cohort study, we may have and 2 comparators, one population or one population with 2 comparators. It is a retrospective cohort study. If we have a prospective cohort study, we have one population with one or different intervention procedures, but the study is clinical prospective, is not a randomized control trial. We don't have a randomization process, which is very important in randomized control trials. We may have in cohort prospective studies, we may have a selection bias, which is we try to minimize it in randomized control trials. We don't have an allocation concealment of the teeth that we used. So these are the main differences between cohort studies and randomized control trials. And I would like to answer to the question of Mohammed that we did see all these studies for the qualitative synthesis of the results, not for the quantitative synthesis, for the meta-analysis, because we did see separate the results of each study. So for someone who is not very familiar with this study, it seems this seems strange, but we evaluated separately the result of each study and separately the result of randomized control trials, separately for the results of cohort studies.
So your study actually contains 3 studies, 3 sub-studies in that. Am I right?
Yes.
Great. So this is a very good answer to that question, because that question arrived from the participants to me. So I'm happy that you explained that. So this study has 3 subtypes and completely separate from each other. Great. George, good job. Fantastic. Dr. Vatanpur, you have a question. Please go ahead.
Hello, everybody. Actually, I have some question from the PICO part, and because it's not clear for me, the PICO question. If it's possible, I want to know exactly that which intervention or which interventions compared with other comparator. And also I want to know exactly about the participants. In the PICO section, you mentioned that in the intervention part, you mentioned that vital pulp therapy in teeth with complication crown fractures. And in comparator, you mentioned other type of vital pulp therapy. I want to know exactly in intervention, which which of the treatment of the vital pulp therapy was your intervention aim, and it was compared with other treatment of vital pulp therapy.
Yes, in some studies, the authors had done direct pulp pumping, for example, with two materials, calcium hydroxide or MTA. In other studies, we have the same material, either direct pulp cupping of partial pulpotomy was done. So this is that is what we mean with other type of vital pulp therapy. We had two types of vital pulp therapy with one material, with one type of vital pulp therapy with two materials. This is the explanation of this issue here. If I covered you, I don't know if I answered the question.
Dr. Vatampur, do you want to add anything, or are you all right?
As I understood, Dr. George wanted to have a comprehensive and systematic review about all of the aspects of these treatments. But yes, I want to suggest that to have several PICO questions for each part, one question, to be more clear for readers. And because I think there is some mistakes in combining data, in pooling data, because we have a lot of different confounding factors like age, type of study, and so on, that we cannot rationally pool the data of different of these studies with each other. Then I think if we want to have several sub comparison or sub study, it is better to have several PICO questions for each confounding or for each factor, separate PICO question. And also, I have a question about and comment about
Dr. Vatampur, sorry, can I add something to your comment? The question, George, means that when you have subtype of studies, the PICO of them should be different. What do you think about that? I mean, talking about the cohort, so the PICO for cohort should be different from the PICO for RCT, and retrospective should be different from prospective. Am I right, Dr. Vatampur? Do I understand your question?
Yes, surely. Exactly.
Yeah. Okay, Giorgio, what do you think?
Yes,
that can be one of the lack of these things in your publication.
Yes,
that
yes,
you put the PICO for all these three subtypes all together. And the previous question that confused others as well was related to that. However, I understand now what is it, but in the publication, it's not very clear.
Yes, I understand the comment. Obviously, we have a lot of confounding factors, but we can make 3 or 4 different PICO questions, more general PICO questions, and we have some subgroups after for the meta-analysis and the quantitative synthesis. I understand completely the comment, and I agree. But we don't have any other road to
Yeah.
conduct something like this and to make a synthesis of the results quantitatively. I would like to add that this was the first time in such a study we tried to combine all the results and to have some meaningful results. I think that the only strange result is that calcium hydroxide perform similarly with MTA. And there is no difference between pulp capping and pulpotomy procedure. But if we think the result, this is all these cases are cases of dental trauma and cases with young patients. And before dental trauma, there is no irritation of the pulp tissue. The irritation of the pulp tissue happens when during the moment of the dental trauma. So we had a previous irritation like caries. We have bacteria, and there is no previous irritation. So the bacteria do not have the time to colonize the tissue and to provide an inflammation of the tissue. So in my opinion, my personal opinion, I think that pulp capping in cases of trauma, if pulp capping is performed on time, I think that it has the same results with partial pulpotomy. These results are very different in case of caries. We have an extensive pulp inflammation, even if the caries is not in the pulp chamber, inside the pulp chamber.
Great. Okay, thank you very much indeed.
Okay.
And also there is another question about the mixture of the open apex and mature apex in your study. So is it okay to put all this variable together, especially this maturation has a very important effect?
We can think it again regularly because all these patients are young patients. There is no difference if the patient is 8 years old or 12 years old, because 12 years old central incisor is immature and 12 years old is mature. Is there anyone who believes that there is a difference in the healing potential of the tissue between these two cases? I don't think so. No. So I think that we can provide a pool result both in immature and mature teeth.
I would separate them and compare them by testing that to find it out, is this variable has some effect on the result or not? Because if they have some effect on the result, then we may say that based on the evidence. Obviously, your opinion is okay, but you can easily, with your data, you can easily compare them with each other. So that can be another thing that you may think about.
The problem, Mohammed, is that many studies did not provide how many immature and mature teeth.
They already mixed that, you mean?
Yes, we have this problem. And I think
this was also your question actually on the forms, because I'm not very sure your tables. But they say that some of the studies try to classify the maturation of the root, but most of them they didn't.
Yes.
I see on the tables on the.
So I think this is also give us the importance of standardization in the publication. So if the publications in the future follow the guidelines to give all the information, future systematic review becomes much easier. So if you look at the International Endodontic Journal, they have actually then a series of the guidelines that if we follow those guidelines, then every details of the publication will be available for the future systematic review and meta-analysis. Thank you. Okay, Utku, please.
So we already mentioned about the aims of the study, so I will not spend many times in here. So before material and methods, I wanted to just give this evidence-based pyramid, which is really, really important for us. We see that meta-analysis is the top of our pyramid. So thank you very much again for this very precious research. And also protocol registration and reporting. Dr. George already mentioned about these details, so I will skip them a little faster. But the important part is terms of search. I saw these names on the additional table, and I just wanted to ask you, first of all, how did you decide for searching the terms? I mean, how did you decide what will gonna include it, and how did you decide which one going to be excluded? And also, I haven't seen that the reattachment terms. Maybe for the next research, we can also think about that, because reattachment is getting popular in vital therapies also. And thank you. Can you explain us for how did you decide?
Yes, always the search strategy is not an easy procedure. I think, is my opinion, that you can anyone can be advised by an expert on this topic, because we have to combine several terms. We know that we use or and and to combine similar or different terms. In these cases, we try to use some terms we believe that we covered the topic about the topic of interest, and I think that the initial hits, the number of initial hits was 500 articles, almost, I think. And after by hand searches, we believe that we retrieved all the articles that were necessary for this systematic review.
Yeah, I see that only one research which is included to 24 of one of them. It's only one of them has a complicated crown root fracture. So do you think that this is also when we include the root fracture, we don't use vital therapy, or this is because of the searching terms?
I didn't understand you, Utku.
My question was, when we check the type of the fracture, I only see that one of the research only have the crown root fracture with a vital therapy. So do you think that when we include the root fracture, generally we don't use vital therapy, or this is because of the searching terms?
No, because it is another type of fracture, and this type of fracture needs some other treatment. In some cases, we need to have an orthodontic movement of the tooth in order to have a clear line above the periodontal tissue. So this is the reason we do not use this term.
Okay, thank you. So study design, we see that RCT, prospective clinical
excuse
trials,
me,
cohort,
please.
yeah, sure.
Please, Dr. Vatanpur has a question.
Excuse me, Dr. George, I want to know that did you do backward and forward search? Backward search and forward search for a comprehensive search of the articles.
backward and forward search. Dr.
Yes.
Vatanpur, can you explain what type of search is this?
Sometimes for a comprehensive search, we search first the articles of one author, and then from the reference of that articles, we search about another author, and from that article also we search about the articles, because as you know, for example, some of the researchers all around the world have a definite research line and work on some subject, some specific subject. For
Yes.
example, Dr. Torabinejad works on MTA. Then when you search about MTA and some of your article, in some of your article, you found that Dr. Torabinejad is the author, it is better that you search the articles of the Dr. Torabinejad also.
Yes.
This is the backward
no,
search and forward search.
no, we didn't do that. We didn't do that. I think that if we use the proper terms through the search strategy, at least the articles that the relative articles, you're going to find all the relative articles, irrespective of names of materials used, I think.
George, but I think even if you look at, for example, your own article, you will find this problem, because sometimes author may not use the proper keyword in the title or even in the keywords. Therefore, I think this is a very good suggestion to use this type of a strategy of the search in the future to find it out if there are some famous name in that particular subject that you can find it by your initial search. Go back and just find and search their name to make sure that maybe we can find something in the particular person publication. If I understand correctly, Dr. Vatanpur, if not, please correct me again.
Yes, exactly.
So the idea is, if, for example, Professor Abu Tahun works on a particular line, and during this first initial search, we find it out his name is prominent, we should go and just look at all of his publication. This is the idea. I think it is good to have some sort of improvement for our future out of this journal club. If you agree, George, for that.
I don't have a specific disagreement, but how can we write this inside the article?
Dr.
How can we justify this type of search?
In the PubMed, you can, for example, in the PubMed, you can write the name of the famous researcher.
Obviously, we're going to do this, but in the article, how can we write this
backward forward search strategy is the name. Backward forward search strategy.
Yes.
This is a new idea of searching before final selection of the article. And even for myself, it happens for myself. Yes. Because, for example, I publish a lot of articles about Apex locator, and sometimes when I put Apex locator, I couldn't find my name. The reason is, unfortunately or fortunately, I used a proper name of root canal length measurement device rather than Apex locator. Because yes. Apex, we don't locate Apex. And I claim that this is not a scientific name and must be electronic root canal length measurement devices rather than Apex locator. And because of that, nobody can find my article when they search about Apex locator. So if in first and initial search, you find it out my article about apex locator is prominent, you may decide to search about some of the final authors backward. So, and when you write it down in your article, you say that backward, forward research strategy has been done for the list, for example, for these 4 or these 5 authors, something like
okay.
that.
Okay.
Thank you very much, Dr. Fatanpour, for
Welcome.
describing that. It is also new for me as well. So today we have actually 2 new ideas, one by George about the explanation of the differences of the material, and if a material is a novel, a good material, the result shouldn't be calcification, and backward, forward research strategy. Thank you both. Okay, let's go.
Thank you very much. When we continue with the participants, all participants undergoing vital pulp treatment in both mature and immature after complicated crown fractures. And comparators, we already mentioned about that, so I will skip a little faster. And outcome, the outcome that we want to see, and exclusion criteria. Case reports were excluded, and studies included previously treated patient teeth, as well as studies with ineligible results were also excluded. So what examples of ineligible results can we give, Doctor?
In sometimes you have you retrieve some studies with irrelevant results. As I previously see, I can mention a study by Boltas and Pavlika in 2003. I think it's about root canal treatment in Polish people, but there are some results and some findings about vital pulp treatment. This was an example of a study with ineligible results. I think that there were other studies with ineligible results that were excluded from the analysis.
Okay, Dr. Fatanpour has got some comments. Dr. Fatanpour, please.
I want to discuss about inclusion and exclusion criteria. Exactly, I want to mention that, for example, in this study, case report is not an exclusion criteria, because a study which is case report basically not included in the in your article. Then exclusion criteria, the definition of the exclusion criteria is the criteria which during the study we should exclude it. For example, in your article, irrelevant studies which you find after assessment of your article in the, for example, 186 article, you exclude because duplication. This is an exclusion criteria. Or for example, 291 article excluded by title and abstract assessment. These are exclusion criteria, but case reports basically not included in the article.
I think, Dr. Fatanpour, somehow methodologically, if you want to be very picky, you are right. But on the other hand, the result is similar, because even if you don't mention case reports are excluded because the inclusion criteria was something else, I do agree with you, but I think the outcome is similar to each other. I don't know, what do you think, George?
I think that I agree with you, Mohammed. I think also a recent systematic review by Donnelly and Hal Duncan, I think they mentioned, the authors mentioned that case report and case series were excluded. And
yeah, because sometimes we
was,
want to emphasize that the case series and case reports are not high-level evidence and we exclude them, something like that. But I understand the point that Dr.
we excluded
Vatapur tried to
anyway.
say.
Do you mean that we excluded any way? This is trying to. Okay.
Yeah,
But,
I understand that as well. Yeah, okay. Okay,
but I
let's
agree
move.
with you that the result is similar, I think.
Yeah. Thank you, Dr. Vatapur. Okay, Utku, please.
And data were extracted and recorded in standardized pilot forms. And these forms included specific characterization of study and information on study design, title, authors, date, population, interventions, competitors, and outcomes. At this point, I realized something, that you also recorded the contact numbers and emails of the authors. So I know that you already contact with one of the authors. So what was your questions, and was that hard for you to reach them? So because sometimes in all research, it is really hard to find your contact person directly. So did you feel need to contact, and what was the reason?
I think that I had, as I wrote, we wrote 2 personal communications. I think the most important
Hekova.
was the communication with Hekova. An article that was done in 2010. And I think that the reason of communication is that the authors they had not mentioned the pulp capping material, and I think that I wrote to Hekova to specify, to make specific what was the pulp capping material, and she answered me that it was calcium hydroxide. I think this was the reason of communication.
Yeah, and also there was many cases at this research.
Yes.
And I also checked the research, and it was really interesting for me not to find any calcium hydroxide or capping material. But sometimes they're missing. I think that was important for me. It is easy to reach the authors for the research. And summary measures and data synthesis. And we also already mentioned about this subject, and we can skip, I think. And also we saw that he recorded more than 500, and only 24 articles included the qualitative synthesis, and only 7 articles for meta-analysis. And study design characteristic, we saw that 24 studies and 4 randomized clinical trials were identified, 6 prospective core studies and 12 retrospective core studies, and 2 case control studies. And we see that reported mean age of participants was reported to range between 8 to 20. So at this point, I see that mostly for the vital therapy, we are putting this therapy to the young people. Also, at this meta-analysis, we see that only until 20 years old. We know that the trauma is mostly happening at the young age, at the childhood times. But I also have many patients who is more than 20 years, 30 years, even 40 years old, who has a trauma with complicated crown fracture. So do you think that this is the choice of dentist, that they don't want to put vital therapy to the major teeth? And do you think that they need to change their mind, and we should try to put this vital therapies also for the people who has more than 35, 30, 60 years old, even in 50 years old?
I think, Utku, that you already mentioned the reasons for that. It's dental trauma. The age range is very tight. But for sure, we should change our minds in order to provide vital treatment if it is appropriate, the appropriate treatment plan. And I think it is very important to the vital part treatment to be a viable treatment option inside our office. I think in case of caries, the age range is very more wide. And we can see that we can apply vital part treatment also in ages of 40 and 50 years old of patients. But in dental trauma, this range is very tight, so we are limited to patients with an age between 8 and almost 20 years old of age.
So pulp survival and maintenance of the pulp
the only question that I have, sorry, for the age, as you mentioned, when we are talking about the trauma, so the majority of the trauma cases are young people, obviously. So the number of the cases that we can evaluate and analyze it is limited as well.
Yes.
George?
Yeah. I didn't hear you, Mohammed.
Oh, sorry, George. Sorry, George. My question was about the age of the patient that are under trauma, because most of the cases that you showed from the articles, they are very young people, already young people. They are exposed to trauma.
Yes, the majority of the cases were young people. Yes, I don't understand the question.
No, it's not a question. I mean, because you don't have enough data for people that they are not older, you cannot actually jump to the conclusion for that people that they are older. Data showed that it works for young people.
Yes, I agree.
But
the only thing that I try to emphasize is just to be careful about do not overgeneralize the data without enough data. Something
yes,
like
yes. You are right. Yes.
Thank you.
But also, Professor, Dr. Nekofer, when we look to the researches, we don't see research with a vital therapy with people who is more than 20 years old. I think the only reason
this is something else,
trauma.
This is something else, because this article is concentrated on the trauma. And we know that, and already Professor George mentioned that when we have trauma, we don't have bacterial contamination penetrated to the apical part of the root canal system.
Yes.
That is the theory behind the idea. Obviously, yes, you're right. If we want to run such a study, we can run a randomized clinical trial for that purpose.
Thank you. So pulp survival and maintenance of the pulp vitality was identified as the primary outcome of interest in all identified studies. This was assessed through clinically radiographic follow-up examination. And we see study design and characteristic outcomes mostly involved absence of clinical signs and symptoms, such as spontaneous pain or pain to percussion or palpation, mobility, crown discoloration, swelling, and sinistrate. Radiographically, we see that root canal thickening and absence of the periapical lesion were common secondary outcomes. Whereas an array of study on immature traumatic teeth included assessment of progression of root formation and determination of root length and or apex closure. And also we see that evidence from 2 studies comparing a bioceramic material versus calcium hydroxide in immature teeth didn't reveal significant intervention effects. That was very important for me. and we will see it in the discussion part again. Likewise, a non-significant findings was observed when MTA was compared with calcium hydroxide. And also, there was no evidence that pulpotomy performed better than pulp capping with either calcium hydroxide or MTA. In addition, considering single study estimates about outcomes related to root formation in immature teeth, findings from a single study didn't support a difference between the probabilities for progression of root formation between biodentin and MTA. Similarly, evidence from another study indicated a non-significant mean percentage increase in root length of traumatized teeth when treated with either MTA or SMNN. Last, considering single study estimates about the effect of concomitant periodontal injuries on pulp vitality and survival, no significant difference was detected in teeth treated with MTA. So before talking about the discussion part, I want to ask you that what is the difficulty of conducting clinical trials in this field? I see at the beginning of the discussion part, it is really hard to find some studies to compare to each other because of standardization difference. So for you, for your mind, what's the difficulty of conducting these clinical trials?
I think the difficulty is is great. I have not tried to perform a clinical trial in the field of dental trauma and complicated crowd fractures, but I can say that I have performed, and I'm during the completion of this trial about partial pulpotomy in teeth with reverse pulpitis, in mature teeth with reverse pulpitis. I'm going to submit it to the International Audit Journal, and the difficulty is great because you need to control several issues during the study. And the most important part and the most difficult part is the follow-up examination, because we have several problems with patients to come to the office to make a follow-up examination, 1 or 2 or 3 follow-up examinations which are required in order to document the outcome. The randomization process is a very difficult process. The blinding process is a very difficult process. I think that the blinding process is more difficult than randomization process because there is a documented subjectivity during the trial, and you need to have some colleagues which are not related to the study, in order to make an objective examination of the radiographs of the patients, and this is a very difficult task, I think.
Okay, thank you very much, Utku. We just have 8 minutes.
Okay, so let's continue a little faster, I think. And so about the inclusion criteria, I'm keeping that. And this words was the most important for me, the most important part of the discussion. He says that one might speculate that framing and following a LHRT's clinical procedure and established methodology is of considerable importance in the first place, whereas the comparison between a calcium hydroxide or a calcium silicate material for pulp survivor of traumatized teeth might play a secondary role. I think this is very important to see that the most important part of our treatment is following the main basic rules. You say that. In my opinion, it is also same for the root canal treatments. And sometimes we say that some bad standard root canal treatments are successful. We see that even with the not good radiographically, but I think this is also same in here. The most important part is not the material, not the type of the injury, not the size of the perforation. The most important part is late artist. I think this is very good take-home message for all of us. What do you think about this part of the study?
Yes, I agree with you very much, Utku, because I think the procedure is of major importance. It's for sure that nowadays we don't use calcium hydroxide. We have other materials to use, calcium silicate materials like MTA or other materials like biodentine or total fill. I have not any conflict of interest, just mention these materials. So we have the opportunity to achieve a favorable outcome using these materials, and the most important thing is that we don't have bacteria, and it is very easily if we manage a trauma case on time to clean the wound surface and to have a clean tissue where we're going to put the material, the pulp capping material, and to have a favorable outcome. It is very important. In addition, it is very important to say that we included all the studies, even if they had 3 months or 6 months of follow-up examination. We know that nowadays such studies are not published. We need a larger follow-up examination, but these studies are already published, so we have to deal with these results. And the rationale behind this, the inclusion of such studies, is that in dental trauma we do not have bacteria. The failures, if the process is not going well, the failure is early, is in the majority of the cases early and not late failure. If we have a late failure, I think, in my opinion, it's not due to the process, but due to coronal leakage in the majority of the cases. If the restoration is not going, I think it is my opinion. I think.
Okay, Utkut, thank you very much. Utkut, how many slides do you have? Because we just finished the time.
I think we finished almost, because this was the summarizing whole we talked for today. So mainly from this article, we can say that the most important thing is periodontal injuries stage and capping material, type of vital pulp therapy, or stage of root development do not affect our prognosis for a short-term results.
Yes.
Okay, thank you very much indeed for joining us, being with us, and thanks to the author of this amazing publication, very informative, very knowledgeable, very useful article, to accept our invitation to join us to this Journal Club. And the recorded session is ready in our website. So please, all of us, put our hand together to Dr. Giorgio. George, please, you pronounce your name.
Tzanetakis.
Professor George Tzanetakis, thank you very much for joining us.
Thank you all for the invitation, and thank you all for your comments. That all your comments will be very useful in the future for me, and thank you all very much. Thank you all very much.
And please join us for our future sessions as well. And also, I should say thanks to Dr. Utku John, because Utku, we asked Utku to do this job in a very short notice. Utku, we wish you all of the best for your future career in Bahçeşehir University. To this
Thank you very much.
certification also gifted to you as well. We put our hand together for Utku. Utku, thank you very much indeed.
Thank you very
So
much.
I want to
You're
ask
so kind.
two pioneers and two professors to end up the sessions for us. Professor Zimet first, and we give the stage to Professor Abu Tahoun for the final talk. Professor Zimet, please unmute yourself.
Thank you, George. That was and thank you, Utku. That were both outstanding. It's extraordinary that you read a paper, and when I listen to this, I have a totally different view of the paper, because listening to the author, I have 101 questions, and you explain the questions that I was thinking about. Why do you include such short length papers, which to me really make no sense at all? And you explain to me, it's nice to hear why a 3-month paper in your vision is still relevant. So thank you very much. Thank you to both the author and the reviewer, and of course, the moderator, who as always makes it very exciting for us.
Thank you very much, Professor Zimet, for joining us and transfer your energy to us. George, please, you go.
Thank you very much for all your kind words. I tried to do my best to explain the rationale of the study and our thoughts during performing the study.
Thank you. Professor Abu Tahoun, the stage is yours, and close the session, please.
Thank you very much, Dr. Mohammed. A really great session. Thank you very much. You were so, you showed mercy, and you were very kind with Dr. Tzanetakis. You didn't, and the most important for me is that the fact is that lately there is a focus in the literature in endodontic on treatment of traumatized teeth with internal, external resorptions, avulsions, horizontal root fractures. I don't know, which is the topic that is mostly discussed today. And this will be an add, of course, to our knowledge in this field. While what we are aiming at by these techniques is to produce hard tissue formation. We were discussing why we have hard tissue formation, why we have calcifications in the canals. Anyhow, I think successful outcome is measured, is defined by lack of symptoms and also by disappearance of periodical lesion. Once we have these, I think all the other things shouldn't be of major concern, because still we don't have a noble material for this. I would like to thank also all those who participated in this discussion, and first of all, Dr. Tzanetakis, who represents my mother university, University of Athens. I'm very proud of you, Giorgos. Very proud of University of Athens, and looking forward to future discussions. Thank you very much, all.
Thank you all.
Thank you very much, Professor Ibrahim Abu Tahoun. The presence of Professor Zimet and you with us give us a lot of positive energy, and we are going and moving forward because you guys are supporting us. Thank you very much. And although I asked Professor Ibrahim to close the session, I couldn't resist to ask Professor Tubaturk to give us some opinion, because she is expert. She knows the stem cells, and I think she loves the stem cells, and sometimes she plays with the stem cells rather than just doing the job. Tuba, please.
Thank you very much for your kind words. It was really very amazing to listen the authors about his papers. Also, I think all of us here know the importance of pulp vitality very well. So while you look at the literature for the last few years, you can see that there is a high rise about the pulp vitality studies. I think this is the future. And as the Professor Nekofer always says, the future is the biology. I think the future of endodontics will be the biology. So I'm very happy to be here and to share all these things with you. Thank you very much.
Thank you very much, guys, and see you in 3 weeks. We put two hands together again for this amazing smile of the first author of this journal, of this article. Thank you very much. Again, thank you very much indeed.
Thank you all.
Goodbye
Thank
and
you
see you
all.
soon.
Once again,
Bye.
thank you all. Thank you.
Thank you all. Bye-bye.
Bye-bye. Bye-bye.